Welcome to the Practicing Clinicians Exchange podcast series on improving outcomes in immune thrombocytopenia. This is the first of two podcasts and will focus on factors associated with ITP and initial management. I am Christopher Nelson, a nurse practitioner from the Avera Medical Group Oncology and Hematology Department in Aberdeen, South Dakota. I will be your moderator for today's episode. Joining us today is Dr. Hanny Al-Samkari, Assistant Professor of Medicine at Harvard Medical School in Boston, Massachusetts. This program is supported by educational grants from Novartis and Dova. This program is provided by Practicing Clinicians Exchange for 0.25 ANCC and AAPA credits per episode. To receive credit for this program, go to pce.is/ITP. The learning objectives are that at the conclusion of this podcast, you will be able to define factors associated with primary and secondary ITP, identify conventional and novel strategies for initial management of ITP. All right, so let's start with a hypothetical question. You have a patient presenting with red spots on her shoulders and arms. Her follow-up laboratory work reveals thrombocytopenia. You are suspecting immune thrombocytopenia. How would you confirm your suspicion and proceed?
Yeah, Chris, so this is a great question. Happens all the time. I wish we had a great laboratory test that was widely available and easy to do that could really confirm whether or not someone has ITP. But really, it's a diagnosis of exclusion. You have to make sure that there isn't some other complicating cause or some other cause of the patient's thrombocytopenia. Make sure that they don't have liver disease, some kind of cryptogenic cirrhosis, for example, that hasn't been diagnosed. Make sure they're not on a drug that would cause thrombocytopenia, something that's suppressing their bone marrow, for example, like an infection. We think of ITP as both primary and secondary ITP. Folks who have primary ITP often will have no clear related factors, but oftentimes they'll have underlying autoimmune disease. It's very common for thyroid disease to be present in patients who also have ITP, or they'll have a family history of autoimmune disease. So, a first-degree relative has type 1 diabetes, another first-degree relative has rheumatoid arthritis, and this patient has thrombocytopenia of unclear etiology that looks a lot like ITP. And then in the secondary ITP patients, we really think about patients making sure there's no CLL, chronic lymphocytic leukemia, making sure there isn't some other B-cell neoplasm, making sure that they don't have a viral infection that could be a cause of their secondary ITP, like HIV or hepatitis C. There is drug-induced immune thrombocytopenia, but we really kind of think of that as a different entity because usually when you stop the drug, the thrombocytopenia gets better or goes away. And then there are some other infectious etiologies that we think of in association with ITP, like H. pylori, which is always reasonable to make sure somebody doesn't have H. pylori. But at the same time, we also now recognize that treating H. pylori doesn't often get rid of the ITP, especially in patients in the West. This is something we see more in Asia, where treating H. pylori will actually get rid of the ITP. So I think it's important to recognize that ITP patients have very variable presentation. I mean, everything from shows up with petechiae and purpura all over their body and a platelet count of 2 to is feeling fine and has no apparent problems, has a CBC for some other reason, and their platelet count is 42,000. We don't know why. These all can fall within the realm of ITP. And in many ways, the initial workup, looking for those secondary causes and ensuring there isn't another cause of thrombocytopenia are relevant kind of regardless of what that initial presentation looks like. In terms of how we initially treat a patient with ITP who requires treatment, like, for example, the patient in the vignette who's having bleeding, right? That patient is presenting with bleeding, and that is an indication to treat regardless of what the platelet count is. Obviously, we want to ensure that there's no significant bleeding going on, like internal bleeding, like GI hemorrhage, and a physical exam and history can help us to ensure of that. And we're going to treat most patients, the vast majority are going to receive corticosteroids. So that can be either dexamethasone or prednisone in most cases in the West. And if you're in Europe, prednisolone. Occasionally, we can give intravenous methylprednisolone in patients that are in the hospital, but most of the time we're doing prednisone, typically around 1 milligram per kilogram, or dexamethasone as a 40 milligram times 4-day pulse. And patients receiving dexamethasone pulses may then receive multiple cycles of that over the course of the next several weeks. In those patients presenting with substantial or concerning bleeding, or those patients that are at particularly high risk of substantial bleeding, we'll add IVIG, intravenous immunoglobulin. IVIG will help to bring that platelet count up a little bit faster than steroids. Steroids often take a few days, can be 3, 4, 5, 6 days before steroids really start to work in earnest. Whereas IVIG typically works within 24 to 48 hours to start bringing that platelet count up.
All right. So let's say then that we have an asymptomatic, newly diagnosed adult with a platelet count of less than 30,000. Should they be treated with corticosteroids, or would you just observe them?
Yeah, that's a great question. So this takes us to the updated ITP guidelines from the American Society of Hematology that were released just a couple of years ago. When somebody who's newly diagnosed and does not have bleeding, because remember, bleeding is an indication to treat no matter what the platelet count is. If their platelet count is less than 30, the guidelines recommend that we should treat them with corticosteroids. If their platelet count is greater than 30, then observation is what the guidelines generally suggest at that point. So you might think this is a somewhat arbitrary number, but the reality is that patients who have ITP and again are not on anticoagulation, for example, with a platelet count of greater than 30, they're really unlikely to have any significant bleeding. They typically do just fine. So in that setting, we observe the patient, recognizing that should their platelet count drop substantially below 30, then we can just treat them at that time. But we really do try to minimize using too much steroids in this disease. There's been some data that's been published recently to show that corticosteroids are really overused in every treatment line in ITP. And, we don't want to constantly be treating patients with rounds and rounds of steroids. We really want steroid therapy to be less than 6 weeks, a total of up to 6 weeks of treatment. So if you're doing a prednisone taper, then have them off of that pred at 6 weeks. If the patient has a relapse shortly after discontinuing that taper and their platelet count drops again to the point where they need treatment, again, a platelet count of less than 30 in most patients, then it's time to think about another drug. It's time to think about thrombopoietin receptor agonist, for example, or rituximab, or having a conversation about second-line therapies. There are some interesting studies that have come out recently. A study adding mycophenolate mofetil to first line called the FLIGHT study, adding MMF to first-line steroids. That was published, showing that those patients do seem to fail less commonly than patients treated with steroids alone. Although of note, the quality of life in that trial in the patients on the combined MMF steroids arm was actually lower than the steroid alone arm, suggesting that, again, we have to worry about toxicity from therapy. This is very important. There is some other studies now that have looked at addition of thrombopoietin receptor agonists in the first line. This is not a recommendation at this point, giving TPORAs with steroids or doing specific combination therapy. And the question of rituximab is actually addressed in the guidelines where it's pretty much recommended that patients do not routinely receive rituximab in combination with corticosteroids in the first line. But these questions do come up. Most of the time, we're talking about a short course of steroids. The take home here, short course of steroids as our first line therapy. Think about IVIG in those patients who are having substantial bleeding or you need to raise that platelet count faster. And, there's ongoing studies and ongoing data really being published now, and hopefully we'll get more soon, looking at ways to improve the rate of remission in the first line. I mentioned mycophenolate mofetil, and there are others with thrombopoietin receptor agonists as well.
Okay, so this is something that's coming up quite a bit lately, and I think it's something that we should talk on. Let's say that you've got a patient with chronic ITP who is concerned about receiving the COVID-19 vaccine. How would you advise this patient?
As someone who sees a lot of ITP patients, obviously, we have concerns because infection and vaccination both can be precipitants of an ITP exacerbation. And this is well documented with a number of different infections as well as vaccines. And so we actually looked into this. A couple multi-center studies have been published. Reality is that there is a risk, as one would expect, with an ITP patient who is well controlled and doing fine, getting the COVID-19 vaccine and having a crash. All right, that happens, but it is the minority of patients. It is in the order of 5 to 10% of patients will have a crash. And in my clinical opinion, and the opinion I know of many of my colleagues who take care of these patients, it is absolutely not a reason to not receive the COVID-19 vaccine. We recognize these vaccines are otherwise very safe and effective at preventing severe disease and death from COVID-19. And we want our ITP patients to have that benefit, no question, because we know that getting COVID-19 is almost certainly associated with a higher risk of problems than the COVID-19 vaccine. What I typically do, and there's no right or wrong here in terms of how these patients are watched or monitored, and everybody kind of has a different practice. What I typically do is I'll get a baseline platelet count before they get their dose of the vaccine, and then recheck the platelet count at 1 week and perhaps 2 weeks, depending on how significant history they have of ITP exacerbations. Mostly this is for peace of mind on the patient's part and on my part, but it is appropriate to offer the COVID-19 vaccine to patients with ITP, recognizing that they could have a crash. And by the way, those 5 to 10% of patients have a crash. The vast majority of them are easily treated that with our typical therapies, and their platelet count comes back up. So this is something that is a concern, absolutely, but we now have data to support giving our patients vaccinations, which are obviously much needed.
I don't know if we have any data to support this, but you mentioned checking their platelet count or their CBC for a couple of weeks after. If they are going to develop a thrombocytopenia after a vaccination, how do we know how quickly afterwards it does happen?
Yes. So, it does vary a bit from patient to patient. It's not going to happen the day after their vaccination. Typically, we're talking about developing an ITP exacerbation after a COVID-19 vaccination. We typically expect that on the order of a week, 2 weeks, 3 weeks, that kind of thing. And we always tell patients, keep an eye out for any potential petechiae, blood blisters in the mouth, any other typical symptoms, right? Because even if you check weekly CBCs, right, you may be 6 days off from when their platelet count crashes from 200,000 to 3, right? Because it will happen in a matter of hours, and you can't check their platelet count every single day. So the most important thing really is the patient is self-aware of this potential and will have a low threshold to come in and get a check. But again, just sort of for peace of mind. And it's interesting, some patients, their platelet count actually goes up after they get a COVID-19 vaccine and don't have a great explanation for that. But, inflammatory response, maybe stimulating platelet production and not stimulating additional platelet autoantibodies in those patients, who knows? But it's on the order of weeks.
Interesting. So, I think the other scenario, and I've seen this many times over the last year also, is you have a patient who's gotten 1 or 2 COVID vaccinations, and then they developed ITP, and then they come in and they say, well, should I get my additional shots? Should I get the booster? What should I do going forward? It sounds like you're really encouraging them to continue with a vaccine series.
Yeah. So, the data in particular was for folks that had pre-existing ITP and what was their risk for having an exacerbation. If somebody developed de novo ITP, a brand new diagnosis of ITP after a COVID vaccine, I think that's a separate question. I think that deserves a little bit more scrutiny, recognizing that that's going to be a sort of a different pathophysiology. We don't have a lot of great data for the COVID-19 vaccine in that circumstance. I would take it as a patient by patient discussion. I would talk about the risks and benefits. And, we live in a world now where it's pretty hard to avoid this virus. It's pretty hard to avoid the virus. So more and more inclined to say, administer the additional vaccines, perhaps a different vaccine. We're also, fortunate to have multiple different kinds of COVID-19 vaccines with different technologies. One could consider switching to a different technology from whatever precipitated their initial ITP. But again, that's a more challenging question. That's something that has to be a very thorough discussion of the risks and benefits and closer monitoring than ITP patient who already has ITP getting a COVID vaccine, because those patients are over 90% likely to not have a recurrence of their ITP.
All right. Thank you so much for listening today. We hope you enjoyed this podcast and invite you to listen to our second podcast covering new options for management of refractory ITP and factors to consider in therapy selection. Please visit pce.is/ITP to take the post test and claim your credit for this activity.